Dr. Sherif Naseef, Ustaz Dr. Sherif Naseef, our professor, one of the best people I believe in this country to talk about skeletal dysplasias. Thank you very much, Professor.
Thank you very much, my dear professors and colleagues, who gave me the privilege to be here today and speak one of the most challenging conditions of pediatric orthopedic surgeons, which is skeletal dysplasia. By definition, dysplasia is abnormal growth and development of cartilage and bone. They are genetic. All cases, not almost all cases, are genetic. Therefore, it is crucial for every orthopedic surgeon who faces a case of skeletal dysplasia that he would not start to diagnose or even to touch the case before referral to a genetist. There are more than 200 types of skeletal dysplasia. It's not reasonable that we are obliged to know all of them, but we will discuss only the skeletal dysplasia of importance to the pediatric orthopedic surgery. How to suspect a case of dysplasia? First, I am sorry I will stay a long time in this slide because this slide is the slide that will allow you to understand every case of dysplasia, and then we'll go through every case separately. So, you suspect dysplasia by 3 cardinal signs. First is multiple deformities in absence of joint contractions. Whenever and wherever you are encountered with a case of multiple deformities in absence of joint contraction, a lamp should be switched in your mind that this case may be a case of dysplasia. Okay? That may be a case of dysplasia. The suspicion will be increased if there is short stature, and if there is abnormal facial features, so the diagnosis will be 100% established. So the 3 cardinal signs of dysplasia are multiple deformities, facial features, and short stature. Dysplasia is diagnosed by history and clinical examination, and the only valuable method of investigation is plain radiography. Other kinds of imaging is of no value and is a waste of time in diagnosing dysplasias. It may be helpful to assess the complications or the problems of dysplasia, but not to diagnose dysplasia. Diagnosis of dysplasia is achieved by clinical examination and by plain radiography. There is no specific treatment of dysplasia. Treatment is either corrective osteotomy, is either lengthening of bone or decompression of neural compression, but there is no specific treatment of dysplasia. The bone, any bone, is composed of physes. I think it's very difficult for this screen to fix. This is the physis, okay? The epiphysis, the metaphysis, and the diaphysis. Physis, epiphysis, metaphysis, and diaphysis, these are the 4 types of dysplasia. Physeal dysplasia, epiphyseal dysplasia, metaphyseal dysplasia, diaphyseal dysplasia, and finally mixed dysplasia, epiphyseal, metaphysio, diaphyseal, and so on. So, the physis is in charge of endochondral ossification. Not appositional, but endochondral, which means growth in length. So, physeal dysplasia is expected to be accompanied by short stature, which is the main problem in physeal dysplasia. The epiphysis is in charge of joint formation. So epiphyseal dysplasia is suspected to be accompanied with joint destruction. The metaphysis is in charge of remodeling. So metaphyseal dysplasia is accompanied with deformities, whether angular or rotational deformity. And the diaphysis is in charge of bone stock or bone formation. So diaphyseal dysplasia is accompanied with thickening or abnormal formation of bone cortices. What kind of deformity do you look for in case of dysplasia? Look first to the growing sides, the elbows, the knees, and the spine. Do not forget to seek these three sides in diagnosing a case of dysplasia. Again, classification of dysplasia is physeal, epiphyseal, metaphyseal, and diaphyseal, and the last is the mixed type. Physeal is abnormality in the physis, so there is abnormal endochondral ossification, either severe, which is achondroplasia, or mild, which is hypochondroplasia. Epiphyseal is abnormality in the epiphysis, so either it affects the epiphysis of the tubular bones only, which is called multiple epiphyseal dysplasia, or the tubular bones and the spine, which is called spondyloepiphyseal dysplasia, or half of the epiphysis, which is called hemimilic epiphyseal dysplasia, or dysplasia epiphysealis hemimilica, or diffuse affection of the epiphysis, or punctate affection, or dysplasia punctata. The metaphysis is either metaphyseal dysplasia per se, unique metaphyseal dysplasia, or affection of the metaphysis close to the physis, which is hereditary multiple exostosis, or affection of the metaphysis close to the diaphysis, which is multiple enchondromatoma. The diaphyseal dysplasia, as we said, the problem is in the diaphysis, either diffuse thickening of bone or osteopetrosis, or localized thickening of bone. Now we are going to pass through all these kinds of dysplasia in short. Physeal dysplasia, affection of the physis. So there is affection of the endochondral ossification. Where is the endochondral ossification? In three sites. In the tubular bones, not long bones, tubular bones. Tubular bones means long bones of the limb and short bones of the hand and feet. Okay? And the pedicle of the spine and the base of the skull. So you clinically, as we mentioned, that you diagnose dysplasia by clinical examination and plain radiography only. So clinically, you will not miss the case. You will see the characteristic facial, the characteristic first short stature. All of them are dwarf, but this is disproportionate dwarfism. There is shortness of the limbs, but more than shortness of the spine, of the trunk. You know that, you see that the hand does not reach the middle of the thigh, but the upper of the thigh only. You will see the characteristic facial abnormality. Why? Because the physis is present in the base of the skull. So the base of the skull has endochondral ossification, while the vault of the skull has membranous ossification, which is not affected. So you will find a large triangular face with bossing and depressed nose. The spine is affected only at the pedicle with lumbar lordosis. And the deformities. Where to seek the deformities? Seek the knees, find genovarum, seek the elbow, we'll find dislocated radial head and ligamentous laxity. These are the signs of deformity. Plain radiography, you will find large vault of the skull and narrow base. Large vault of the skull, membranous ossification, narrow base, endochondral ossification. And in tubular bones, you will find irregular physeal outline, but the epiphysis is normal, the metaphysis is normal, and the whole bone is short, either in the thigh, in the legs, in the forearm, and look at the dislocation of the femoral head. And we also said that the physis is present in the pedicle of the vertebrae, so the intervertebral foramina will be shortened, and this will suffer in adult life with compression of neural compression that may need decompression. Second type of physeal dysplasia is the amygdalar form, which is hypochondroplasia. This patient comes only with short stature, but not severe as that of physeal dysplasia, of achondroplasia. Is any case of short stature considered hypodysplasia? Certainly not. It has a characteristic pattern. Look that the shortness is in the proximal parts of the limb, the upper limb, the arm, and the thigh. But the leg and the forearm are normal. Second is epiphyseal dysplasia, which is affection of the epiphysis, and the epiphysis is in charge of joint formation. So you will see that the epiphysis is fragmented, and the differential diagnosis of such case will be Perthes disease if it is in the hip region. And any case of bilateral Perthes, you should exclude epiphyseal dysplasia. If it includes also the spine, it's called spondyloepiphyseal dysplasia with lumbar lordosis, barrel-shaped chest. And whenever we say that there is barrel-shaped chest, we should differentiate it with mucopolysaccharidosis or Mork's disease. And the spine and the end plates of the spines are affected with possible subluxation of the atlantoaxial joint. And this is Mork's disease, mucopolysaccharidosis. It's typical as spondyloepiphyseal dysplasia, but with subluxation of both hips. The half epiphysis will be affected, dysplasia epiphysealis semimilica, with appearance of mass, or punctate appearance of the epiphysis, as in case of the dysplasia epiphysealis punctata. And this is found only by radiographic, plain radiography. This is a case of metaphyseal dysplasia with genu-valgum. How to differentiate it with other cause of genu valgus? By the plain radiography, you'll see that the metaphysis is elongated, flask-shaped Erlenmeyer metaphysis. If the metaphysis is affected close to the physis, it is multiple exostosis. You cannot miss it. Multiple bony heart swellings affecting single or more bones with cancellous tissue and a cap of hyaline cartilage, and deformity of the elbow, dislocated heredial head, short ulnar deviation, and it may compress on the nerves or on the vessels with ischemia or tingling, numbness, and may develop malignancy in 5% of cases only in the form of chondrosarcoma. If the metaphysis is affected close to the diaphysis, this is multiple enchondromatoma with, if it is accompanied with multiple hemangiomata, it's called Maffucci syndrome. Okay? Diaphyseal dysplasia, diffuse thickening of bone and encroachment of the medullary canal, either localized or diffuse. This patient may live and die, and he does not know that he has diaphyseal dysplasia unless it is discovered accidentally by plain radiography with the character. And I think Dr. Professor Tariq Tawil will tell us more about osteogenesis imperfecta. But you should suspect that there will be anemia due to the encroachment of the medullary canal and hepatosplenomegaly due to extramedullary embolus. Localized form either miliariostasis on one side or osteopoikilosis, dots or striation, or what's called osteopathia striata. Finally, the mixed dysplasia, we have only two conditions. First is nail patella. Whenever you saw, first is hypocleidocranial dysostosis. Whenever you see dysplastic patella, look at the face and the dentition. And you can suspect it by dropping of the shoulder and by bringing the shoulders together. Last case is the hypoplastic patella or nail patella syndrome. Whenever you see hypoplastic patella accidentally by X-ray, look at the nail, look at the pelvis and the lateral subluxation of the elbow. Thank you very much.